So we're continuing on with our discussions of anatomy with motion as the central meaning piece or the central piece of the semantic network or the network of meaning, right? So we're considering cervical extension here. So in considering cervical extension, we've already talked about cervical flexion. So much of what we will do will have some overlap. So there will be some things that will overlap fairly well and some things that will obviously be dissimilar with respect to the specific pieces of anatomy, especially the specific pieces of muscle. So the main objectives here to have a specific discussion of what extension is. So we're going to talk about planes and axes as we did with respect to cervical flexion. Now this is going to be the exact same discussion, but it bears repeating for just the nature of repetitiveness and repetitive exposure to further embed that piece of information or those pieces of information. We're going to have a specific discussion of the muscles that extend the neck, specific discussion of head extension versus neck extension, a general discussion of the neurovascular supply, and a general discussion of areas to assess and treat should cervical extension issues be suspected or reported by the patient. Now, in talking about the areas to assess and treat, just a very simple giveaway. Anything, as I've said before, basically above the clavicles, you're considering the same stuff almost all the time, right? So you're considering the clavicles themselves, the first two ribs, the neck generally, the SCM very specifically, the head on the first cervical, and the cervicals generally. So all the musculature, all the bones, you're considering those very, very generally. You will assess those in some way, shape, or form, and then you would treat what you found, regardless of what you thought was going on. But those are the things that you will consider. And general note, with respect to cervical flexion, cervical extension, and then cervical side bending and rotation, we're not necessarily going to speak specifically about particular conditions that you would find. We will, in the cervical side bending and rotation, note the thyroid and the parathyroid, right? Or actually, we'll probably note that more likely when we're speaking about the hyoid muscles more accurately, because we want to talk about movement of the hyoid, although it doesn't necessarily move the neck per se, it moves the hyoid, which will allow for other functions to occur. So we'll likely talk about that at that point. All right, so as far as planes and axes, so planes are the three cardinal planes, generally speaking, cut the body into 50% pieces. The sagittal plane cuts the body into 50% left, 50% right, so straight down the middle. Right, the horizontal plane or the transverse plane cuts the body 50% top to bottom. The frontal plane cuts the body 50% back to front. Axes for motion. So you could have translation, which is motion straight across a plane, or in most cases in the human body, unless it's a conjoint motion, you can't, like I can translate my hand, but my hand itself doesn't translate. My hand in conjunction with my arm very generally can create translation versus most movement. So for me to get my hand into this position, I have to rotate my hand. So there's an axis. The axis is perpendicular to the plane. So in the case of the sagittal plane, it's a transverse axis. So it's the sagittal plane, transverse axis, or horizontal axis, depending on how you'd like to say it. So with respect to flexion and extension, they move, it's bilateral motion forwards and backwards as a rotation along a transverse axis in the frontal plane. So flexion forward, extension backwards. This does get confusing sometimes. This can be called dorsal flexion. This can be called regional flexion. It depends on how you want to set up your points of attention, but we will simply call this extension. So head extension and cervical extension. So which muscles? Very broadly, we're talking about the trapezius, the levator scapulae. So for the trapezius and the levator scap to create extension, the shoulder blades have to be still. So as far as relational motion is concerned, both move the shoulder blade and both move the neck. So when the shoulder blades are bilaterally still, and you contract the levator scap and the trapezius bilaterally, you will get essentially cervical extension as well as head extension, right? So you'll get both. If both of those muscles go, you have the suboccipital muscles, so the rectus capitis major and minor, obliquus capitis superior and inferior. So those will be head extension on its own. You'll have the semispinalis capitis and cervicis, capitis for the head, cervicis for the neck. You will have longissimus capitis and cervicis, and then you will also have splenius capitis and cervicis. Right now, you do have some other small intersegmental muscles, but we don't need to concern ourselves with those too much because they're present essentially the whole way through the vertebral column. So we'll talk about that at another point. But those are very, very generally speaking, the muscles that we're talking about writ large, right? So we kind of covered them very, very briefly, but basically they're all on the back of the neck. They're going to attach, in most cases, either directly to the spinous process and then some other portion, or to the nuchal ligament. So the nuchal ligament is essentially the posterior, I think it's the supraspinous ligament actually, as almost like a fin, right? The nuchal ligament is almost a fin. So if it was to come to the nuchal line on the occiput, you have this nice long line of connective tissue pulling away or projecting away from the spinous processes and connecting to the spinous process. So the muscles that will be bilateral and kind of superficial to the neck, so trapezius and others, will more or less, instead of connecting to directly the spinous process, connect to the nuchal ligament, right? Now, so it's not pictured here, but you have a general idea. So head extension, to speak specifically about head extension, it is a relatively still neck and a moving head. So this is cervical extension. My head's going to go, but this is head extension. So if you were looking at it from the front, the chin would move and the neck in a relative sense would not. So for that, you have rectus capitis, posterior, major, and minor. So when you see capitis, it's with respect to the head. Then you're going to have obliquus capitis, superior and inferior, splenius capitis, semispinalis capitis, longissimus capitis, SCM, because the SCM, while it will flex the neck or the cervical spine, it will also extend the head, or that is the claim when done bilaterally. And then the trapezius, because the trapezius is attaching to the nuchal region as well as a portion to the mastoid process on the temporal bone. Now, as far as neck extension is concerned, so the head is going to look like it's going back, and you may get head extension when you have cervical extension, but the muscles that are going to do that, so again, cervical extension, head extension, the chin will move, but not much else, or the whole thing will move as a unit. And you'll get both head and neck extension in most cases, but they differentiate from each other because head extension, you just see the chin move, whereas cervical extension, you'd see everything move. Now, we're talking about here the trapezius, as already discussed, the levator scapula, because there is some connection to, in some circumstances, in and around the cranium, but it may not always be the case. Splenius cervicis, semispinalis cervicis, and longissimus cervicis. Rather, I made a mistake with levator scapula. It's because it's to the cervical vertebrae and not the cranium, because we're talking about head extension, or neck extension. So please excuse me as I'm moving fairly fast for that mistake. So the levator scap goes from the scapula to the cervical vertebrae, not the head. But again, we're talking about splenius cervicis, semispinalis cervicis, and longissimus cervicis, as well as some other intersegmental muscles that we're not really going to touch on. But that's neck extension. So you can see, if we compare the amount of muscles for head extension versus neck extension, there's, relatively speaking, without the inclusion of the intersegmental muscles, more muscles for head extension that are considerably smaller, and less muscles that are considerably larger for neck extension. Now, as far as nerves are concerned, you're going to think about the spinal accessory nerve for the SCM, so head extension, right? And you're going to think about the spinal accessory nerve for the trapezius, or essentially head and neck extension, as well as shrugging the shoulders. So that's the spinal accessory nerve. So spinal accessory nerve, very superficially, if somebody were to do this and this, right? So they kind of went like that. That's the full spinal accessory nerve in all its functions. So shrugging the shoulders, extending the neck and head. So the head extension is trapezius and SCM, and then the neck extension and shrugging is trapezius, and then to some degree other muscles will be involved, but as far as the spinal accessory nerve, that's what we're looking at. The segmental branches and the dorsal scapular nerve for the levator scap, so there's going to be some anterior primary rami. So the dorsal scapular nerve is going to be going forwards from this mixed spinal nerve, and so that you get some segmental branches. I believe it's C3 and C4, depending on the resource that you look at, but you also have some innervation, motor innervation from the dorsal scapular nerve, which is a part of the brachial plexus at C5. Everything else, as far as the rectus capitis, superior and inferior, rectus capitis major and minor, obliquus capitis superior and inferior, your splenius, splenii, your semispinalis, and your longissimus what you're looking at there is dorsal primary rami. So as you can see in the picture, if you looked at the vertebral column or the bone, right, of vertebrae, so what you have is the point. If you're looking down at that picture, the point going backwards is the spinous process. So the cord is represented in the middle. You have the mixed spinal nerve. So as it kind of comes out, right, as it comes out, you're going to see an anterior or a ventral ramus, which goes to the limbs and the body wall. And then you're going to have a dorsal ramus or a posterior ramus, which essentially goes back as motor to muscles, like spinal muscles, along the whole cord, and you're going to have some sensory along a narrow strip there. So that's how they all get their motor tone. So anything that is essentially considered a spinal muscle is almost exclusively going to be dorsal primary rami at whatever level that you're looking at. As far as the vascular supply, the vast majority of what we're looking at for the muscles for specifically cervical extension and head extension is you're looking at branches off of the subclavian artery, and you're primarily looking at the thyrocervical trunk as it gives rise to the transverse cervical artery. So a lot of the supply to these muscles that we're discussing is off of the transverse cervical artery, not exclusively. You will get some off of the external carotid. All right, so with respect to the occipital artery, you will get some from the costocervical trunk as well, depending on which particular muscle that we're speaking about. But the commonality is going to be the subclavian arteries, as well as branches thereof, as well as some from the carotid. So the anatomical relationships that you're considering when you're considering arterial supply here is the clavicle, the first rib, and the anterior scalene. So sometimes if you had some reason to believe that there was vascular issues, you wouldn't necessarily see vascular issues in only one area in a presenting patient. You would see some sign of vascular issues through a large portion of everything above the clavicle. Therefore, you would consider these areas, so first rib, second rib, clavicle, the SCM, generally speaking, especially because of the carotid sheath carrying the common carotid and the internal carotid. So you're considering these things quite generally for everything clavicle up. But if you're talking about knowing anatomy for the sake of knowing anatomy, then we're really thinking about the thyrocervical trunk and the costocervical trunk for the muscles of cervical extension, and then very, very similar distribution for venous drainage and lymphatics, right? So the venous drainage, you're considering your jugular system to the subclavian system, so branches in there, the brachiocephalic trunks, right? The brachiocephalic veins, rather, as the subclavian mixes. You're going to, again, be considering the exact same areas, right? It's the clavicles, the first and second ribs, the SCM, the neck, generally speaking, for any form of vascular issue. And then as far as lymphatic drainage, again, you're considering the exact same places, especially because the right side of the head and neck and the right arm drain into the right lymphatic duct, and then everything else for the whole body, including the left side of the head and neck and the left arm, are going to go into the thoracic duct, but those don't both dump into the subclavian veins on their respective sides. So again, clavicle, first rib, SCM, scalenes, but the neck, generally speaking, are all going to be the areas of consideration for assessment and treatment. Right now, as we already noted, the upper ribs. So we've noted this, but we're going to be, again, reiterating it for the purposes of being clear and repetitive. The upper ribs with respect to the scalenes. So the scalenes become important because so you have essentially, as far as anterior to posterior, the contents of the thoracic, superior thoracic aperture is the most common term. You'll have thoracic inlet and outlet, and people will have conversations that they consider funny about, well, it depends on if you're looking at the artery or the vein, because one's in and one's out, right? But you'll have discussions about the inlet and the outlet. So you could have outlet, and then at the bottom of the ribs, the inlet, or you could have the inlet, and at the bottom of the ribs, the outlet. So to deal with that, it's the superior thoracic aperture. But you have the SCM, and then directly posterior to the SCM, and the clavicle, you have the subclavian vein, then you have the anterior scalene, and in between the anterior and middle scalene, you're going to have the passage of the subclavian artery, as well as the brachial plexus, right? So those first two ribs, the clavicle, the SCM, are all very important for neurovascular passage, especially when considering both supply and drainage to the head and to a large degree to the arm. Right, so these are areas of high confluence of anatomy just because of how they course, right? So the upper ribs here are important with respect to the scalenes and the spacing between all of these structures. Should there be mechanical dysfunction, that does relate well to symptoms or signs that relate to the specific vein or artery that is under consideration. Clavicle, as we already noted, this is an area of mechanical dysfunction that puts pressure on varying muscles, varying arteries, varying nerves, the SCM for vascular consideration. Now, the cervical vertebrae, generally speaking, so if you're considering specifically cervical extension, a lot of what you're considering is the posterior or the dorsal primary rami to the spinal muscles. You're considering some other nerves on the anterior side for the SCM, well, really spinal accessory nerve there, the trapezius and the levator scap. You're considering these things, but you're not necessarily going to pick apart exactly where something is. You're going to notice the gross dysfunction in the general regions that we're discussing. But the cervical vertebrae, generally, if you're considering nerve issues, especially motor nerve issues, it would just be if there is a mechanical dysfunction with a particular set of vertebrae that relates well to, or their motion characteristics that relates well to pressure on the nerves, leading to some form of paralysis or palsy that makes cervical extension not possible. If that happens to be the case, then you'd be considering those cervical vertebrae. Now, the head on the neck itself, so head on C1 for head extension, also because of how some of the nerves course. And then you're also going to consider, in this case at least, the scapula. You're going to think about the scapula. If you're going to check the clavicle, right, the scapula is going to move, but you're going to put some attention on the scapula itself because of the connections to the trapezius as well as to the levator scap. So you have maybe very, very similar assessments and treatments that you'll do for the clavicle and the scapula. It's just for one of them, for the clavicle, you'll put your attention here. For the scapula, you'd think about your attention on the backside of the body. So you're using similar movements in most cases, but you're placing your attention in two places instead of one, right? So that's very, very generally what we're considering with cervical extension. Now, just as a general concept, as we noted with cervical flexion, if cervical extension is limited, it is very unlikely in most cases that it's going to be due to a vascular or neural problem with the actual extensor. So the blood supply and the nerve supply to the actual extensors is not likely the problem. What you're more likely seeing is some form of restriction on the anterior side where the cervical flexors that we've already discussed do not want to go through their full range or their full length or relax. So you're considering more likely than not something that you can deal with on the sensory side. So you can change how those cervical flexors are behaving for a short period of time such that cervical extension would be improved or essentially brought back to its full capacity. If you see an extension problem, it's probably not it's probably not a problem with the structures on the back. It's probably an issue with the structures on the front that are responsible for the flexion. The flexion won't let go, so you can't get to extension, as opposed to extension won't happen. Extension not happening, if you asked for extension to happen, and so you made sure that the patient understood, and you asked them to go into extension, nothing would happen. Their head would stay relatively still. Whereas if there's a problem with the anterior surface, what you're going to see is some motion that is considered incomplete. So those are general considerations anatomically, as well as the areas that you would assess and treat. Again, making sure that we note that a lot of this is redundant. Anything clavicle up, all of these things end up being very similar for where you would assess and where you would treat.